I'm going to move on to our next speaker, Dr. Mira Nair-Harhe. She is an associate professor of medicine and transplant nephrologist at Drexel University College of Medicine and associate professor of epidemiology and biostatistics at the Drexel University Dornsife School of Public Health in the great city of Philadelphia in Pennsylvania, where I was born. She's a director of clinical research at the Tower Health Transplant Institute in West Reading, Pennsylvania. She did her medical school residency, nephrology, transplant fellowship, and a master's degree in clinical epidemiology and biostatistics at the University of Pennsylvania. Her research interests include physical, cognitive, and metabolic function in kidney disease, health policy and inequities in kidney transplantation, and the development of new technologies to improve treatment for kidney disease. Her work is funded by several different organizations, including the National Institutes of Health, the National Science Foundation, the Pennsylvania Commonwealth Universal Research Enhancement Program, and the Coulter Drexel Translational Research Partnership. She also serves as a member of the ASN Policy and Advocacy Committee. I'm really looking forward to her talk today titled Racial Disparities in Preemptive Deceased Donor Transplantation and Potential Solutions. Thanks, Dr. Harhe, and thanks for being flexible.
Of course. I just sent a warning to my husband that my children have to be quiet early. So hopefully that works.
Loving the headset.
Oh, thank you very much. Yes, well, hopefully that'll dampen the sound in the background. So I am going to try to share my screen. Hopefully this works out. Can everyone see? And can everyone see my PowerPoint?
Yep, you're great.
Yep. Hello? Okay, great. All right, thank you so much again for the invitation. And so you heard the title of my talk. These are my financial disclosures, and I have no conflicts of interest related to this content. So 3 objectives today. One is to discuss the substantial benefits of preemptive waitlisting for kidney transplantation under our current kidney allocation system in the United States. Second is to examine evidence of persistent racial disparities in access to this option. And third is to explore potential solutions for these racial disparities. So first, I'd like to start off with a tale of 2 first kidney transplant evaluations. The first is a 55-year-old male with diabetic nephropathy, a recent serum creatinine of 3.3 milligrams per deciliter, other comorbidities, hypertension, hyperlipidemia. This patient is still working. He is employed with private insurance, and he's coming for his first kidney transplant evaluation. His nephrologist saw that creatinine of 3.3. His kidney function has been hovering a little bit with creatinine levels lower than that, but that level prompted this evaluation, and we'll talk about why in this patient. Another patient this kind of patient that I saw a lot more when I started working at a safety net transplant program at a hospital that was a safety net hospital, was a 55-year-old male, diabetic nephropathy. But this patient was being evaluated for the first time for kidney transplantation after being dependent on dialysis for 3 years. The patient also has multiple comorbidities, hypertension, hyperlipidemia, like the other patient that I just talked about, but also with that toxic combination of dialysis and diabetes, developed peripheral vascular disease, cardiovascular disease, and is disabled, no longer working, and is Medicare covered. So both of these patients that I've described, if they're healthy enough, could potentially be waitlisted for transplantation. And our kidney allocation system, although it changed a few years ago, still allows for what we call preemptive waitlisting. So that first patient that I described, if their eGFR is 20 ml per minute or lower, could qualify to be waitlisted for transplant. Now, the kidney allocation system changed to allow that second patient who had been waiting on dialysis for 3 years to get that time back so that their clock, their waiting time would be effectively 3 years if they were listed that day. But that first patient who's coming in potentially with a GFR that qualifies them of 20 mLs per minute or lower, gets a very profound benefit if they're waitlisted at that point. And I'll talk about why. So first of all, let's talk about preemptive kidney transplant waitlisting as the very high bar that it is. So I'm talking about being listed for transplant before you ever need maintenance dialysis. So first, you need early diagnosis of your chronic kidney disease. You need primary care, you need preventative care. You need to then be referred to a nephrologist in a timely way, not right before you need dialysis, but well before you might need dialysis, because there's so many interventions that can make a difference and change the course of disease. You need to have that nephrologist follow you up very regularly for evidence of progression. And that nephrologist also needs to talk to you and educate you about end-stage kidney disease, all the different modalities and benefits of different modalities. And so, and at the point when your GFR could potentially qualify you for waitlisting, which in the United States, again, is 20 ml per minute, they need to refer you to a transplant program. And that patient that needs to go to the program, maybe go to not just one visit to be evaluated, but some programs might have them see a cardiologist or other specialists, so multiple appointments. And then that program has to accept that patient for waitlisting before they need renal replacement therapy. A very high bar is what we're talking about here. And how does that translate in terms of who gets waitlisted before they ever need a renal replacement therapy modality? So you're looking at USRDS, the annual data report, and you're looking at people who are incident end-stage kidney disease patients by year on the x-axis, and you're looking at by race, ethnicity in the different colors. And so basically, if you kind of box out the last few years, you see that as a proportion of all people incident end-stage kidney disease, Asian patients have the highest proportion of being preemptively waitlisted before requiring some kind of renal replacement therapy, followed by white patients, then Black African American patients, and then Indigenous Americans and Alaskan Natives. So, you know, that's waitlisting. What about actually getting a transplant before you ever need dialysis? So this is by many people considered to be the optimal thing, and it's very patient-centered too. The goal of avoiding dialysis really is a huge, patient-centered goal. But this is a rare outcome. So between 2003 and 2012, there was a study that looked at preemptive transplants, and they found that, and I'll show you this by race ethnicity, 41% of preemptive transplants came from deceased donors. The majority were coming from living donors. Those people that get preemptive transplants have a survival benefit. There are lower costs of transplant compared to dialysis, more freedom, better quality of life. And though there are some recent studies that suggest that graft outcomes are comparable compared to those who get a transplant after starting dialysis or even with longer dialysis exposure than those who have preemptive transplant. However, like I said, this is rare. So this is looking at, again, the USRDS 2018 data report, and you're looking at these the first renal replacement modality by race ethnicity. And the green boxes are preemptive kidney transplant, which, as I told you, is a majority is living donor, but about 40% are deceased donor transplants. And you're looking by race. So the first box there are white patients. Then those green boxes within are preemptive kidney transplant. It's a very small proportion. So 3.2% of white patients have preemptive transplant as their first modality, renal replacement. But you'll see that that green box is even smaller if you look right next to the white column, and that's for Black and African Americans. So 3.2% of white patients have preemptive transplant as their first modality. 1.1% of Black patients have preemptive transplant as their first modality. And if you look at the denominator a different way, in terms of who's getting these preemptive transplants, if you look at it as a denominator of all transplants. This was a study in CJASN in 2019 that looked at all transplants by race of the recipient. And in the blue, you're looking at the proportion of all transplants in white recipients that were preemptive. And you could just see that, 2018, it's over 20% of all transplants performed for white recipients were preemptive, compared to much lower numbers in all the other race ethnicity categories. And if you look at other features of these, of who gets a preemptive transplant and who doesn't. So, if these boxes are not adding up the columns of preemptive and non-preemptive, but if you do that, so of 14,620 preemptive transplants, about 70% were going to white recipients during this long study period. But there were also differences in education status. So those with higher education more likely to get a preemptive transplant, and those with private insurance more likely to get a preemptive transplant than those with public insurance. Now, I told you that preemptive transplant is pretty rare as as the initial modality of renal replacement therapy, but preemptive waitlisting, that high bar that I was talking about, has benefits that are beyond preemptive transplantation. So this is a study that we did just to explore whether people who were listed preemptively had differences in the amount of time they were waiting on dialysis for a transplant before and after the kidney allocation system. So you're looking at two different groups of recipients. The top recipients on this graph are people who were listed after dialysis, and the y-axis gives you the number of years that they were spending on dialysis before they got their transplant, and the x-axis is over time. And so people who were listed after dialysis were waiting before the new kidney allocation system. We're waiting on average between 4 to 6 years on dialysis for a kidney transplant before they got their transplant. And that bump that you see at the dashed line is when the kidney allocation system changed, prioritizing people who had waited even longer to receive a kidney transplant. So you're seeing that effect. But basically, you're talking about many, many years waiting on dialysis. But if you look at the bottom group, those are people who were listed before starting dialysis. And you can see across all the race ethnicity groups, people were waiting between 1 to 2 years before getting their kidney transplant. The lowest in the blue were the white recipients who were listed before transplant, and the green are the Black recipients. So there is still a spread even within those who were listed preemptively of how long you waited, but that difference was profoundly lower than the people who were listed after dialysis. So let's just break down these requirements a little bit, just thinking about why these differences might exist. So I talked about early diagnosis of chronic kidney disease, referral to a nephrologist, follow-up for progression. Why might there be differences? So we know, again, based on the USRDS data, that if you look here at the percentage of people who are getting pre-end-stage kidney disease care, basically, care from a nephrologist, you can see in the blue and the green and blue box, the light blue boxes, these are people who had no pre-dialysis care or unknown, really. And so if you compare white to Black patients who are with end-stage kidney disease, you can see that more of them fall into that, no care, unknown amount of care before end-stage kidney disease category. But if you break it also down by insurance status, you see similar differences where these green and light blue boxes are more in the people who are starting with end-stage kidney disease who are uninsured or who are in their waiting period for Medicare. So perhaps some of this difference is being driven by insurance and the cost of insurance in the United States. So this was something of interest to me and colleagues when the Affordable Care Act was passed, and Medicaid expansion in particular as one of its provisions was passed, because we know, and so on the right, you're looking at the difference in uninsured rates in states that expanded Medicaid and didn't expand Medicaid by race ethnicity. And so in expansion states, the darker boxes, you can see overall that uninsured rates are lower than in non-expansion states, but the gap of who remains uninsured is wider in the racial and ethnic minorities who live in these non-expansion states, states that didn't pass Medicaid. So we knew that. And in one study we did, we we found that Medicaid coverage, just in the overall population with kidney disease, if you looked at NHANES, which is sort of a national estimate of the population, you can estimate who is covered by Medicaid with kidney disease. And so we did that over a 7-year period, and there were increases in Medicaid coverage in Black people with kidney disease, Hispanic people with kidney disease, and in the lowest income people with kidney disease by large proportions over that time, coinciding with when Medicaid became available to more people across the country. And this was a study that was published in JAMA that I think really kind of underscores insurance as an issue. For getting preemptively waitlisted, you need health insurance to be listed for transplant. And if you look at, so this study was looking at outcomes of people who started dialysis before and after Medicaid expansion. But I'm just pointing out one figure that really drove it home for me from this study, so in the top figure, you're looking at patients with Medicaid coverage in expansion states in blue and non-expansion states in the orange, and you can see Medicaid coverage increased as expected for patients starting dialysis in expansion states as expected. But look at the proportion underneath of uninsured patients in non-expansion and expansion states. So, starting off in 2011, 30% of people starting dialysis in non-expansion states, non-elderly people who wouldn't qualify for Medicare by age, 30% were uninsured. And if you look at 2017, that number dropped a bit, but it's still over 20% of people starting dialysis uninsured in non-expansion states. Basically, virtually no chance of being waitlisted for a kidney transplant before starting dialysis. And we have studied how Medicaid expansion might have impacted preemptive waitlisting. In this study, we found, and this is looking at waitlisting events, that Medicaid expansion was associated with an almost 60% increase in Medicaid coverage for people who were preemptively waitlisted compared to a much smaller increase in Medicaid covered preemptively listed patients in non-expansion states. And you can see that Medicaid covered preemptively listed transplant candidates look very different from overall preemptively listed and transplanted recipients, in that they're much less likely to be white. They're more likely to be Black or Hispanic than people without Medicaid coverage with private insurance. But there are differences in terms of whether or not they're working, because remember that Medicaid expansion really allowed for more people and childless adults who are working but have low incomes, perhaps at minimum wage, to achieve affordable health care. So there are differences in terms of whether they have good functional status as well, because Medicaid, again, by expanding Medicaid to people who are not disabled, more people who are working and more people who have functional independent function could be eligible. And we see those differences in the demographics of transplant waitlisting. And so you can see that if you look at that dashed line, that's the time of Medicaid expansion, that there was a real difference in who was getting transplanted with waitlisted preemptively with Medicaid coverage. And if you look at who that affected by race, you can see that comparing non-expansion to expansion states and pre-expansion in the light blue and post-expansion time in the dark blue, that the increase in listings with Medicaid coverage was higher in Black candidates, Hispanic candidates, and people with other race ethnicities. So, and we kind of followed that up with a study that looked at actual changes in preemptive kidney transplantation. So we know that these listing changes happen with Medicaid expansion, but what about transplant? So this is looking at who received a kidney transplant with Medicaid coverage in the pre-expansion period throughout the United States, in places that did and did not ultimately expand Medicaid. And this is looking at the post-expansion characteristics. And so there were differences or changes in race, ethnicity after Medicaid expansion. The main difference I would just point out is that in non-expansion states, Medicaid covered preemptive transplant candidates are still more likely to be white. But that's not true in expansion states. There are also differences in whether they're working. In non-expansion states, Medicaid covered recipients are less likely to be working, 17.5% versus almost 27% in expansion states. And this is just looking at that same difference over time and who is getting a Medicaid covered kidney transplant. And you can just see that in expansion states, it's maybe less dramatic than listing, but that increase of Medicaid covered listings. And that deceased donor, because it's a smaller proportion, these confidence intervals are wider, but that same difference starts to happen, really kind of more Medicaid covered deceased donor transplants as well. So we know that Medicaid coverage increased Medicaid covered transplant wait listings, Medicaid covered transplants preemptively, and that those differences were more profound in racial and ethnic minorities. And we know that there are missed opportunities because if you look at on the left, the kind of hot spots for end stage kidney disease in the United States on the left compared to where Medicaid expansion hasn't happened on the right, that we really are looking at places where there are a lot of people who are probably uninsured that could be insured before starting dialysis. But one of the questions that comes up is why aren't those numbers higher, even higher than I showed you? And what we don't know and what we need to know is how many nephrologists and primary care physicians are actually accepting some of these Medicaid expansion beneficiaries. And there was one study in this was just in Florida that kind of lumped nephrologists with a lot of other specialists that actually less than 60% were accepting new Medicaid patients. So perhaps we could do better in actually providing access through increased insurance coverage. I wrote with a colleague in the UK, a perspective about this was our question because I had done some of this work about Medicaid expansion, and then this study came out from the United Kingdom, and we asked the question, will universal access to healthcare mean equitable access to kidney transplantation? And the United Kingdom study that we were commenting on in Jason really suggested that that's only the tip of the iceberg, because in the United Kingdom, which has the NHS, which is basically universal coverage, there are still racial disparities in preemptive kidney transplant waitlisting, a much lower odds in Black patients compared to white patients for preemptive waitlisting. So that's not the only thing. And what about things like nephrologist education, referral to the transplant program? One of the important studies that came out in Jason in 2018 really suggests that we are the providers of healthcare have to have better awareness about racial disparities in waitlisting, because that might be driving some of the problems that we're seeing in terms of differences in access. So a 2016 survey across the United States asked providers of all these different types that you're seeing nationally, do you think that African Americans have lower waitlisting rates than white patients on average? 19% of providers were aware of this difference, and white providers were more likely to be unaware of this difference, this disparity, and also facilities that had a very, their own disparities in waitlisting were more likely to be unaware about racial disparities nationally. There are education interventions that are being tested, patient navigator, ways to try to increase that part of getting a preemptive transplant evaluation that might have to do with awareness of kidney disease. In one a single study intervention, they required a group education class. This was to increase awareness and decrease loss to follow-up among people who were coming for their first transplant evaluation. And in 1 year, the 80.4% of those who got that intervention completed their evaluation versus less than half of the control. And this study found that intervention alone was much stronger among Black patients and patients living in poor neighborhoods. And what about evaluation by the transplant program? So we have, the education piece. We have, questions about why, what we understand about these disparities, which is probably not enough. But what about just getting through the door differences? So I gave you 2 patient vignettes, right? And I told you about this 55-year-old with a male with diabetic nephropathy and a serum creatinine of 3.3 milligrams per deciliter. I purposely left out here, I did not assign these patients a race ethnicity. And the reason that I didn't do that was because I wanted to show you what happens if you use the MDRD equation and that 3.3 milligrams per deciliter for that patient, if that patient should be not Black race. And so that's on the left. And that gives you an EGFR of 19.6 ml per minute per 1.73 meters squared. And again, based on our allocation system that qualifies for waitlisting. What if that patient wasn't, what if that patient was Black, however? So if you plug in those same numbers, you get an eGFR of 23.7 ml per minute per 1.73 meters squared. That does not yet qualify that patient for waitlisting. And this has come up. I know there's a national conversation, so many passionate voices about this race multiplier question, and the fact that race is not a biologic risk factor, right? It's a social, we have to talk about social determinants of health when we incorporate race, but it's not a biologic risk factor, right? So when you look at those two calculator equations, there have been some studies that talk about what this might actually mean for transplant access and give some ideas. So in one study, they found that the CKD-EPI equation with the race coefficient overestimated measured GFR by 3.1 ml per minute. So basically in Black adults with stage 2 to 3 CKD. And over 4 years of follow-up, the use of CKD-EPI without race actually led to a 35% higher probability of an estimated GFR of less than 20. And so for transplant, that actually has big implications for who can actually get on the list. Another study looked at over 2,000 Black patients in a northeastern US health registry, and they found that by removing the race multiplier from the CKD-EPI equation, 3.1% of that cohort would be reassigned from an eGFR of greater than 20, not waitlist eligible, to 20 or lower. So a very, very recent study looked at using CRIC participants, basically compared how much time, what does this actually amount to in waiting time for, if you make this difference in terms of GFR. And so they compared how much time could be accrued for non-Hispanic white and non-Hispanic Black participants based on which estimating equation you used to estimate their kidney function. And so if you used eGFR creatinine and eGFR cystatin C, Black participants had over 30% shorter, not shower, shorter waiting time before ESKD onset. So same patient comes in, you use one equation versus the other, huge impact on how much benefit they can get from that preemptive waiting time. And they estimated that registering Black patients on the waiting list at a higher GFR, 24 to 25, would yield more equitable waiting time accrual. So even if you overcome all those barriers of actually getting through the door to the kidney transplant evaluation, just simply by changing that equation, you might be talking about years of difference in terms of waiting time that you can accrue before ever needing dialysis. And then acceptance of the transplant program before requiring kidney transplant. Renal replacement therapy, we should acknowledge that there are differences in progression of kidney disease. So in a VA study from 2018, so again, health insurance is kind of taken out of that equation. These are people with access to care. Over 56,000 veterans with stage 4 CKD and over 600,000 with stage 3. And the nephrology referral rates in this study were actually higher in the Black and Hispanic veterans compared to the white veterans, but the Black and Hispanic veterans had faster progression to stage 5 than white veterans. So we're back here to our tale of two patients. And I hope I can tell you, though I didn't give or assign these patients a race ethnicity, that the patient on the left has numerous potential benefits to coming in when they did to get their transplant evaluation. And we need to, and I hope I also convinced you that this patient on the left is much less likely to be a Black person than a white person. And there are lots of ways that we can address that and should address that. In one, we published a perspective piece with colleagues about, kind of all these steps that I described and all the different barriers that might be contributing to the racial disparities. I've touched on some, not all, insurance barriers, the race modifier in eGFR, and I haven't touched on it nearly enough, this idea of structural racism and other social determinants of health that we have, that we would take a day or more, probably a week, to really talk through all of these issues. But we gave a lot of different potential remedies, things about physician education, which we clearly know is not adequate. And I thank the organizers for letting me talk about this issue, because this is a way to get this information out there. But we went through a lot of different potential remedies, and then we gave one that I think was kind of, maybe the most radical of the potential remedies, which was to basically take away this option. Stop the option of this huge benefit of getting a preemptive, of being waitlisted and accruing all that preemptive waiting time, acknowledging that there are such differences in the amount of time that people, the amount of kind of burdens to get through the door, and also the potential extra time that you get. And so that might seem radical, but my colleagues and I that wrote this, we reached out to our international colleagues, and just to try to understand how the United States and our practices differ from the rest of the world. And what I'll tell you is that our policy, which is a GFR of 20 or lower, and basically unlimited accrual of waiting time. So people who come in because they have that care, and because, and potentially can delay their onset of end-stage kidney disease through our newer therapies, if they have access to them, can just accrue so much waiting time that they may need little or no dialysis time before a transplant, is really the exception. Australia, Germany, British Columbia, Korea, all these places don't have this preemptive waiting list time. And other countries really require either evidence of a consistent decline in kidney function, or the nephrologist to basically attest to this patient's going to need dialysis within 6 months, for example, in the UK. So we're really the exception, and we have to kind of think about what that means for the disparities that we clearly observe in this outcome. That's the dog. So conclusions, preemptive kidney transplant is very beneficial to patients. So is waitlisting, not just transplant. But we know that racial and ethnic disparities are really kind of pervasive and driven by issues that are including the cost of care, differences in kidney disease progression, and many other reasons. So what are the solutions? Better awareness, education, outreach, support, GFR calculators that don't create this big difference, listing policies to incorporate progression into disease progression differences, perhaps, are another way. And I know questions will be at the end.